Okay, now we will talk about the patient with personality problems. This is the last um, chapter of the presenting complaints section of this book. So this is the patient with, no, it's not the last. We have the personality, the patient with neurodevelopmental disorder after that. And after that, we will begin with causes and management. Anyways, so let's talk about the patient with personality problems. The description and okay, the description and management of what has been arbitrarily designated personality disorder is one of the most controversial subjects in psychiatry. They overlap substantially with the concept of neurodevelopmental disorders, but are currently considered separately. Classification changes are underfoot, with the draft version of the ICD-11 proposing substantial changes. And actually, that's what happened in DSM-5, in the section 3 of DSM-5. Okay, the alternative personality disorder model. Okay. So, people use the term personality with varying meanings, even within the psychological and psychiatric specialties. Amid the lack of consensus on what defines personality, there is little doubt that some people seem to experience and interact with the world in a manner markedly different to other individuals in their culture. Personality disorders are important. They are common, associated with significant distress to the sufferer, and often with great cost to healthcare and social and criminal justice agencies. Let's take a look on some definitions and clinical features. Personality traits are enduring patterns of perceiving, thinking about, and relating to both self and the environment. So, enduring patterns of perceiving, thinking about, and relating to both self and the environment. Exhibited in a wide range of social, personal contexts. A personality disorder is when an individual has traits that are persistently inflexible and maladaptive, are stable over time, appeared in adolescence or early adulthood, and that cause significant personal distress or functional impairment to the person or those around them. Patients with a personality disorder tend not to regard their patterns of behavior as inherently abnormal. Instead, they usually present to healthcare services with a wide range of problems related or consequent to their abnormal personality traits, like self-harm, feelings of depression or anxiety, violence or disorderly conduct, post-traumatic stress disorder, eating disorders, dissociative or somatoform disorders. Having a major psychiatric illness, such as schizophrenia, does not preclude patients from also having a personality disorder. A diagnosis of personality disorder can be stigmatizing. It is important to consider whether making the diagnosis is useful. For example, if it will direct the patient towards appropriate therapy or direct them away from potential iatrogenic harm. Classification. Personality disorders can be classified into two groups according to their etiology. The first group includes acquired personality disorders, where the disorder clearly develops after and is directly related to a recognizable insult, like organic personality disorder, result when this insult is some form of brain damage or disease, like brain tumor or stroke. A common example is seen in patients with frontal lobe lesions, which can be characterized by social disinhibition like stealing, sexual inappropriateness, and abnormalities of emotional expression like shallow cheerfulness, aggression, and apathy. Patients can also develop enduring personality changes after experiencing a catastrophic event like concentration camp on hostage situation leading to post-traumatic stress disorder, or after the development of a severe psychiatric illness. In such cases, a mental illness rather than personality disorder should be diagnosed. The second group includes what is referred to in the ICD-10 as specific personality disorders. These are far more prevalent and therefore simply referred to as personality disorders. This is the term that will be used for the rest of this chapter. In this group of personality disorders, it is difficult to find a direct causal relationship between personality traits and any one specific insult, although genetic and environmental factors have been implicated. The onset of personality disorders is in adolescence or early adulthood, and any age and any change in symptoms tends to occur very gradually over a long period of time. Personality disorders can be further classified according to clinical presentation, specifically regarding which particular maladaptive personality traits are present. In this regard, there are two approaches: the dimensional and categorical classification. The dimensional approach hypothesizes that the personality traits of patients with personality disorder differ from the normal population only in terms of degree. Maladaptive personality traits can therefore be seen as existing on a continuum that merges into normality. The dimensional approach is used predominantly in the research of personality disorders and is measured by personality inventories like Minnesota Multiphasic Personality Inventory, MMPI. Okay. The ICD-10 and the DSM-5 use the categorical approach. In the DSM-5 we are talking about section 2. Okay. They use the categorical approach, which assumes the existence of distinct types of personality disorder and therefore classifies patients into discrete categories as summarized in the table below. So let's talk about them. Okay, here we have this categorical classification of personality disorders in the DSM-5. We have cluster A, odd or eccentric. We have cluster B, dramatic, emotional or erratic. And we have cluster C, anxious or fearful. So for cluster A, we have paranoid personality disorder, schizoid personality disorder, and schizotypal personality disorder. Paranoid personality disorder, the features are suspects. So patients with paranoid personality disorder suspects others are exploiting, harming, or deceiving them, doubts about spouse fidelity, bears grudges, tenacious sense of personal rights, litigious, litigious, emotional. So another thing is about emotional coldness. Oh no, that's it. For schizoid personality disorder, emotional coldness, neither enjoys nor desires close or sexual relationships, prefers solitary activities, takes pleasure in few activities, indifferent to praise or criticism. This is schizoid. While schizotypal personality disorder, eccentric behavior, odd beliefs or magical thinking, unusual perceptual experiences like sensing another's presence and so, ideas of reference, suspicious or paranoid ideas, vague or circumstantial thinking, and social withdrawal. What about cluster B? We have borderline or emotionally unstable personality disorder. We have antisocial personality disorder, or what's called dissocial personality. And we have histrionic personality disorder and narcissistic personality disorder. For emotionally unstable personality disorder, which is borderline, we have unstable, intense relationships, fluctuating between extremes of idealization and devaluation, unstable self-image, impulsivity in sex, binge eating, substance abuse, spending money, such things, chronic feelings of emptiness, repetitive suicidal or self-harm behavior, fluctuations in mood, frantic efforts to avoid real or imagined abandonment, transient paranoid ideation, pseudo-hallucinations, and dissociation. For antisocial or dissocial personality disorder, we have repeated unlawful or aggressive behavior, deceitfulness, lying, reckless irresponsibility, lack of remorse or incapacity to experience guilt. For histrionic personality disorder, dramatic, aggregated expressions of emotion, attention-seeking, seductive behavior, labile, shallow emotions. Narcissistic personality disorder has a grandiose sense of self-importance, need for admiration. Cluster C personality disorders are dependent personality disorder, avoidant personality disorder or anxious avoidant personality disorder, obsessive compulsive personality disorder, or what's called an ancastic personality disorder. Okay. Dependent personality disorder has excessive need to be cared for, submissive, clinging behavior, needs others to assume responsibility for major life areas, and fear of separation. For avoidant personality disorder, we have hypersensitivity to critical remarks or rejection, inhibited in social situations, fears of inadequacy. For an ancastic personality disorder, we have preoccupation with orderliness, perfectionism, and control, devoted to work at expense of leisure, pedantic, rigid, and stubborn, overly cautious. Here we have a note that the ICD-10 includes all the personality disorders described in DSM-5 clusters above, except for schizotypal and narcissistic personality disorder. However, schizotypal disorder, similar to DSM-5, schizotypal personality disorder, is included in the ICD-10's section of psychotic disorders. Actually, in DSM-5, it is there in psychotic disorder and in personality disorders. Note also that the draft ICD-11 classification of personality disorder include some substantial changes. DSM-5, ICD-10, okay, so that's it. Okay. Despite the widespread use of the categorical approach in clinical practice, it seldom conforms to reality, as there is a considerable overlap of traits and most individuals do not fit perfectly into these prescribed categories. People are often best described as having a mixed personality disorder, listing the specific traits that are causing difficulties. In an attempt to simplify further the classification of personality disorders, the DSM-5 has designated 3 personality clusters based on general similarities. Cluster A describes individuals who appear odd or eccentric and include paranoid, schizoid, and schizotypal personality disorders. Cluster B describes individuals who appear dramatic, emotional, or erratic and includes borderline. Closest ICD-10 equivalent is emotionally unstable personality disorder. Antisocial, the closest ICD-10 is dissocial personality. Histrionic and narcissistic personality disorders. Cluster C describes individuals who appear anxious or fearful and includes avoidant, dependent, and obsessive compulsive, which is ancastic personality disorders. Hybrid categorical dimensional approach is being taken by the current draft of ICD-10, which split personality disorders into mild, moderate, and severe, and refers to 5 prominent traits: ancastic, detached, disinhibited, dissocial, and negative affect, rather than 10 individual disorders. Someone may be considered to have one or more prominent traits, potentially improving the accuracy of the personality description. Okay, hints and tips. Everybody has a personality that, no matter how normal, can have dysfunctional traits like anger, anxiety, idealization, devaluation, obsessive compulsive behavior. These traits often become much more prominent at times of psychological stress, such as mental or physical illness, pain and discomfort, work-related stress, and even tiredness and hunger. It is important to remember that personality disorders occur in many settings, remain stable over time, and cause significant personal stress or functional impairment. So that's about personality disorder. It occurs in many settings, remains stable over time, and cause significant personal distress or functional impairment. You know, to specify what is personality disorder. Another hints and tips. The term borderline personality disorder is derived from the early 20th century psychoanalysts who described a group of patients who were on the borderline between the neurosis and the psychosis. Okay, about communication. Confusingly, the different classification systems use slightly different terms for essentially the same type of personality disorder. Borderline personality disorder in DSM-5 is very similar to emotionally unstable personality disorder, borderline type in ICD-10. Similarly, antisocial personality disorder in DSM-5 is very similar to dissocial personality disorder in ICD-10. The terms are often used interchangeably. Don't be confused if both appear in someone's notes. Okay. So, how we assess these patients? History. As with other mental illnesses, giving a patient a label of personality disorder gives those involved with their care only a limited amount of information. In fact, the clinical classification of personality disorders is often unreliable. And although psychiatrists usually agree that a patient has a personality disorder, there are often differing points of view regarding the subtype of the disorder. Patients with a possible personality disorder often present at times of crisis and distress, and therefore diagnosis at the first interview can be difficult because of the quantity of background and collateral information required, and because diagnosis requires the features to persist over time. A practical approach includes making a comprehensive assessment of sources of distress, like thoughts, emotions, behaviors, and relationships to self and others, and any comorbid mental illness, and specific impairments of functioning at work, home, or in social circumstances. It is usually possible to establish some idea of a patient's personality by taking a detailed history of their life. Again, we need source of distress, any comorbid mental illness, and specific impairments in functioning. Okay. It is usually possible to establish some idea of patient's personality by taking a detailed history of their life, focusing on the areas of education, work, criminality, relationships, and sexual behavior. When patients are not able to describe aspects of their personality, it can be useful to ask how those close to them might describe them. It is also useful with consent to obtain collateral information from the patient's family, employer, and general practitioner, all of whom might be able to provide information to help distinguishing between transient and enduring patterns of behavior. It's important to recognize that patients with a personality disorder may exhibit strong emotional reactions, transference and countertransference, and that they are often perceived as difficult patients because of this. Being aware of your own emotions, often strong feelings of anger or anxiety, and taking a non-judgmental and empathic stance during assessment can be greatly beneficial, as well as providing insight into the diagnosis itself. A number of self-rating questionnaires that focus on personality traits are available. These can be helpful in the diagnosis of personality disorder. However, they should not be used as a substitute for a comprehensive clinical history. Structured interviews are also available, although these tend to be used for research purposes and are seldom used clinically. Let's talk about examination and investigation. There are no specific physical signs that help in the diagnosis of personality disorders. However, the consequences of associated behaviors may be seen on examination or investigation, like marks of self-inflicted lacerations or burns, musculoskeletal injuries from assaults or accidents, the sequelae of drug or alcohol misuse, and sexually transmitted infections following promiscuity. Communication tip. It is difficult to confirm or to exclude the diagnosis of personality disorder without taking a reliable collateral history to establish pervasiveness and stability of presentation. It can be difficult for patients to comment on this objectively, especially if they are in a state of distress. What about the differential diagnosis? A personality disorder should not be diagnosed if symptoms are better explained by a physical problem, substance misuse, or a mental illness. Almost all the mental illnesses described in this book can feature some of the behaviors that characterize personality disorders. Examples include social withdrawal, suspiciousness, and odd ideas in schizophrenia, self-harm, low mood, and poor self-image in depression, aggression, irresponsibility, and impulsivity in substance misuse or mania. The diagnostic task is also complicated by the observation that many patients with major mental illness or intellectual disability also have a concurrent personality disorder. A personality disorder should be only diagnosed when the clinical features begin in adolescence or early adulthood, are relatively stable over time, and do not only occur during an episode of a major mental illness like depressive or manic or psychotic episode. Again, a personality disorder should only be diagnosed when the clinical features begin in adolescence or early adulthood, are relatively stable over time, and do not occur during an episode of major mental illness only. When an individual develops a dramatic personality change after a period of normal personality functioning, consider an organic personality disorder or a personality change that occurs secondary to experiencing a catastrophic event or developing a severe psychiatric illness. Hints and tips. Remember that cluster A personality disorders may present with features similar to the psychotic disorders: suspiciousness, social withdrawal, and eccentric beliefs, but are differentiated by the absence of true delusions or hallucinations. Okay. Let's get back to the case. The on-call psychiatrist was asked to assess Miss BP, a 27-year-old woman who had been known to mental health services since the age of 17 years with symptoms that have been fairly consistent. She lived with her mother, who had contacted services because Miss BP was threatening to jump in front of a bus. Her father had sexually abused her as a child, and she had a long history of self-harm that included cutting and repeated overdoses. Her mother was inclined to challenge her promiscuous behavior and binge drinking, which led to many heated arguments. At interview, Miss BP told the psychiatrist that she was feeling more depressed than ever because her mother had suggested that she move into her own house. With gentle questioning, it transpired that she was afraid that her mother would stop caring for her if she moved out. The psychiatrist, who had known Miss BP for years, recognized that his behavior was not usual for her and was able to help her to see another perspective to her mother's suggestion. Miss BP's mood quickly lifted and her suicidal ideation resolved. Let's discuss the case. So, Miss BP has a chronic condition that first presented in adolescence and has changed little over time. She has a number of maladaptive and inflexible personality traits that manifest as repeated self-harm, suicidal behavior, impulsivity, fluctuations in mood, and marked fear of abandonment by her mother. These characteristics are consistent with the diagnosis of emotionally unstable personality disorder, which is borderline type. It would be important to exclude another mental illness that may coexist with the personality disorder such as depression or harmful use or substance or alcohol. Note that there is an association between emotionally unstable personality disorder and childhood trauma, including physical, emotional, and sexual abuse as in this case. So now you can go to chapter 24, which deals with personality disorders and their management. So we are here reaching the chapter summary. A personality disorder is when someone has ways of thinking, feeling, or behaving that are stable over time and context, manifest in adolescence or early adulthood, cause significant distress to the patient or those around them. The classification of personality disorders is a controversial topic currently being reviewed. Many people have both a personality disorder and a mental disorder. A personality disorder should not be diagnosed if symptoms are better explained by a physical problem, substance abuse, or a mental disorder. هذا والله تعالى أعلم وصلى الله وسلم على سيدنا محمد وعلى آله وصحبه أجمعين.